Good.
Cut. Hello and welcome my dear students. It's 6:40 a.m. very early in the morning and I'm sitting in the Hotel Campanile in Łódź next to Peter Temesvari. My guest is emergency medicine enthusiast, as you are, and I, obviously. Is originally Hungarian, but he also works in the UK. And the reason we are sitting here is the conference KOPERNIK 2019, which we recommend you strongly. Peter was a speaker at one of the conference's lecture. Hey, Peter.
Good morning.
I would like to ask you, what was the reason you as a doctor have chosen the pre-hospital medicine? Because as I know, you work in the Hungarian HEMS, you work in UK HEMS, and you also travel between one and the other, obviously. What was the reason? This was your part of interest.
It always interested me. I like excitement, I like adventure, I always have. But I started out as a surgeon. I trained as a trauma surgeon in Hungary.
Right.
My first 2 years of training was surgery. And I like surgery, but my passion was always for pre-hospital emergency medicine. In those times, it was the last millennium, I'm sorry to say, but we didn't have emergency departments in Hungary. So the only type of emergency was ambulance work, pre-hospital emergency medicine.
How long did you work in the ambulance?
I started off as an assistant, then became a paramedic as a medical student.
Right.
In the last 2 years you have advanced competencies compared to an assistant. You are an advanced level paramedic.
So you have started your journey before you've ended your studies?
I've started the journey while I was studying, so it was third year of university that started, or fourth year of university. That was back in 1994.
1994.
A long time ago. So I graduated in 97 and then started this surgery training thing. But soon I found out that hospital environment is really not for me, for a couple of reasons. Too many patients. I'm not kidding, but when you get older, you feel that if you are surrounded with problems and misery, you get depressed a little bit. In the pre-hospital field, it's very easy. You have one patient, you focus on that patient, and then you hand over the patient, and then you're finished. And you go to the next one. But for me, that was really quite appealing. So I found during the years, many years, that really one patient at a time, focusing on one patient, taking care of their basic needs, making a difference is what I'm after, and not many patients at the same time with minor problems, or not patients who come back to me in a week or 2 weeks or a month and I see them all the time and they grow old with me.
So you compare your work with the ambulatory, but also the ambulatory surgery.
Yes.
But obviously, as a surgeon, you've got one patient on the operating room.
Yes.
Right? But
not really, because you've got many patients in the ward.
I see, on the ward.
And you, as a young surgeon in Hungary, you were basically a slave to the older surgeons. You had to do their paperwork, you had to do all their assisting in the operating room. So it wasn't really inspiring. I didn't need my mental capacities, and I didn't need to see the patient as a whole. When I worked in abdominal surgery, that was a small part of the body. It was a very important part of the body, but it still was some areas of the whole patient and the whole physiology, which you don't see if you're a surgeon. And when I worked in trauma, like orthopedic surgery, limb surgery, that was even worse, because you concentrated on a piece of limb, which is a little bit like DIY at home, with saws and drills.
There is a bone.
There is a
There's
bone.
a fracture. I need to
fix it. And it's true. That's how you look at it. So I wanted to I wanted to see the whole patient. I wanted to make a big difference to the patient's care. I wanted to try to help patients who were in the most dire need.
And it is very curious because you've developed from the assistant of the paramedic, right,
Yes.
to the head director, medical director
Yes.
of
At some point, then I fell.
of
But whatever.
Hungarian HEMS. Tell me about the way that you took. How long did you took, and what was the reason you've chosen the administrative work also?
So there are not many of us in pre-hospital medicine, and not many doctors, and that was true at that time as well. So straight after I switched to the other specialty, I was pretty soon given larger responsibilities. Like I was responsible for medical organization of an ambulance station, which was really good, but I was really young at the time, so I didn't know what really to do, how to handle people, how to motivate them, what to do about training and the rosters. You have to take care of who goes where. It was pretty soon in my career that I was thrown into this. That was a great challenge. I wasn't very good at it at that time. But so it happens pretty quickly in the pre-hospital environment, I think. So you get given responsibilities. At least in my country it happens, or it happened at that time. As I said, not many of us.
Yeah.
So I progressed. I went to work for HEMS, for the air ambulance, and there again, well, I'm passionate about what I do, so I was always enthusiastic. I was always looking for new ways, and my bosses thought that was a good thing, and they might use me for a more management role in the future.
All right.
So I was given the responsibility of managing director of HEMS in 2011. After my years spent in the UK, they thought that my UK experience was really good, and it's very beneficial to improve the system in Hungary. I think it's similar to what Thomas is doing
All right.
at this time in HEMS. Management versus clinical duties. Again, I would like to make a difference. So if you have one patient as your responsibility, you make a difference, you help them as much as you can. But if you're in management, you help hundreds of patients. So I think that's an even bigger challenge, and it's a great challenge because you can help patients, and at the same time you can help younger people, your colleagues. And I thought my goal was basically to make their lives easier, and by making the lives of our colleagues easier, I can help many patients at the same time. And that was my drive, and that's why I went into management, and I didn't regret it. It was brilliant times.
All right. Speaking of management, I still remember very well the 2017 Airmed Congress in Warsaw, where we met for the first time.
For the first time, yeah.
And the reason is that you have organized great workshops for difficult airway management. I have also brought here some of the papers and some of the materials from those workshops. Could you tell me what are the key points of managing difficult airways? If you had to give me 5, or maybe 2 would be enough.
Oh yeah, well I mean, no, I can give you 5 easily. I might have to cheat. This is my own document. I've designed it. So this is just this is something funny. You might want to look it up. If you're interested in cricoid pressure and why not to do it, this is a good talk about why not to do cricoid pressure.
And this is your checklist.
This is the emergencies checklist. So this is crash checklist. So you mean peri-arrest patients, and that's a normal checklist.
And you do it every time.
Each and every intubation.
And every intubation.
And I would say that one of the key elements, one of the key messages, is always use a checklist each and every time, because a checklist. This is, if you intubate a patient who has cardiac output, then their lives are in your hands, literally. There is no way about it. This is going to be the most dangerous part in a patient's life ever, probably. You are intubating
your way
somebody
to-
pre-hospitally. I mean, it's a big, huge thing. And the checklist is there because when they developed this system in the UK, the method of us intubating patients pre-hospitally, and they looked at mistakes they've made along the way, parts of equipment they've forgotten, and key important messages, and they put those on the checklist. And now, because it's on the checklist, it doesn't get forgotten. But the key is to use a checklist for every single intubation, and you should really use a checklist for every very critical phase of your patient care. For example, we have a checklist for post-RAS patients, because you can go easily wrong with post-RAS patients. Cardiac arrest management, ALS, is easy, it's straightforward, there's nothing about it. It's a very easy algorithm. But after return of spontaneous circulation, you can do all sorts of mistakes.
Yeah.
So the checklist is good for that. But going back to your question, key messages. One of the early messages is oxygenate, pre-oxygenate instantly. So as long as you know you're going to intubate a patient, give them maximum pre-oxygenation. This is not about hyperoxic damage. This is about basic preservance of life. So you have to give them as much oxygenation as possible.
Including COPD patients?
Including COPD patients, because for those 10 to 15 minutes, their oxygen saturation and their oxygen supply should be absolutely maximum.
And
this
afterwards,
includes,
they will stop breathing
at some point.
at some point. But if you give them the paralysis,
Then for a while,
the
breathing is not a
it will
problem.
be-
So I wouldn't consider hypercapnia a danger in this patient group at this stage. If it is, you have to mask ventilate them a little bit, but that's a special patient group. For everybody, it needs to be oxygenation maximum. So pre-oxygenation with every method you have. It could be a face mask, it could be a nasal cannula and a face mask at the same time. So 2 times 15 liters per minute, that's the best for anybody who is hypoxic. And for any normal patient, you have to use pre-oxygenation as well. And staying with oxygen, apneic oxygenation is brilliant. You should use it at every patient, because during laryngoscopy, it's a very good way to maintain good saturation, and it's proven, there's good evidence behind it. So you should use, so pre-oxygenate and apneic oxygenate, first message. Second message, probably even more important, you have to get your first intubation attempt successful. And in order to make that, optimize the first attempt, there's a couple of things you need to do. And the most important is positioning. It's not about drugs, it's about patient positioning. You have to have 360-degree access. For obese patients, you have to have the help position. If they're obese, for any patient, the ear to sternal notch position, so the same height, absolutely vital, because the best possible view you can get during laryngoscopy is determined by patient's position and your position. And also these should be standard each and every time. In the pre-hospital field, it's easy because you've got a trolley, you can lower it down, you can kneel behind the trolley, and you can standardize the position, and it's stable and it's standard. Every time, you don't have to think about it, you don't have to do acrobatic maneuvers during intubation, you don't have to use your muscle tone, you can focus on what you're doing, which is important. So, positioning, pre-oxygenation and oxygenation.
apneic oxygenation.
And then drugs, you have to choose your drugs wisely. This is RSI, rapid sequence intubation. Follow your algorithm, it's not difficult, and you have a very good drug at your disposal, which is ketamine for induction. And use a muscle relaxant for every intubation. Don't go down the traditional Eastern European way, where muscle relaxants belong to gods in the clouds who are anesthetists in the operating room. No, muscle relaxants are needed, vital for the success of your first attempt at intubation. Because if you do 2 attempts, it increases your mortality. If you do 3 attempts, your mortality is above the roof. So don't go multiple attempts. Get it right the first time. Position, pre-oxygenate, select your drugs. Do not underdose your muscle relaxants. You should always overdose your muscle relaxants and underdose your induction agent. Because the induction agent can impede your circulation, it can decrease your blood pressure, your saturation, everything. but your muscle relaxants don't do anything like that. The
Because I
more you give,
remember you use both sucks and rocuronium. Yeah.
both can be used.
Yeah, both can be used at the same time, right? So first a little dose of sucks and then
Yes, so
a
that's the
full dose of
rocuronium.
rocuronium.
But that's just for prolonged
Mhm.
paralysis.
Yeah.
If you want, if you're really good, you can decide that after sucks and after the tube is in and the patient is cooperating and you have a sheet hot ventilator, you can decide to let them breathe for themselves. Some patients, maybe COPD patients, or some who are don't necessarily require paralysis. But paralysis is the easy route. So once you've intubated the patient, that's when you have everything in your hands. It's easy to ventilate, it's easy to maintain. In the United Kingdom, we use rocuronium for induction. So that's all in one.
All right.
Sucks is a little bit easier, especially if you're younger, less experienced, because it kicks in quickly. It's nice and stable. We like that. So yes, drugs, position, pre-oxygenate. One of the key messages is somebody's surprised about is use a bougie for every single intubation. Because they say the bougie is a very good backup device. If you don't get a good view, then they get your bougie out. That's not the good way to do this, because using the bougie is a skill. It needs finesse and it needs teamwork. But if you use that teamwork and use the bougie for every single intubation, then it's absolutely second nature. And intubating with the bougie makes your intubation success rate go over the roof. I promise you. It's very important. It's vital. It's sometimes tricky to find the vocal cords with the tube, as we all know who tried it, but it's much easier to find it with a bougie. So just use a bougie.
All right.
Every intubation. Use a checklist.
I'm just reading your checklist, and the first point is telephone advice, and I remember it very well. Is that true that you confirm every attempt of intubation the patient with a phone to your friend?
Yes, that's what we do.
All
We
right.
believe in it. Because yes, we love emergency medicine pre-hospitally because you're on your own and it's a nice challenge, it's a great adventure, and you're in charge. You decide what happens, and these decisions are vital. But you're alone. You are in a team, but your team member is normally less experienced than you. First, you have to consult your team member. That's fine. You should come up with a decision. Does this patient needs intubation? How unwell are they, for example? But if you're in hospital, naturally you would go to your supervisor. Naturally you would call the anesthetist or somebody and show them the patient and ask their opinion if the intubation is really indicated or not.
All right.
Because as I said, it's a tricky, risky procedure. So you have to have your indications correct. And you are emotionally involved in the scene. You've seen it. You see the patient bleeding, suffocating. It influences your decision making. So you need somebody who's far away, detached from the scene, not emotionally attached. Preferably somebody with lots of experience and knowledge. They can be on the phone. It's easy. And a 1 minute, 2 minute telephone conversation. I have a patient like this, looks like that, GCS is like this, blood sugar is like that. Do you agree that we should intubate?
So short report?
Yeah, it's just a consultation. And then advice is given, not judgment is given, not decision is given, advice is given. Okay, based on what you told me, I think this patient needs intubation. What I would do on scene is I would make sure that give them some fluids, keep the dose of ketamine low because they are a little bit unstable, and don't forget to measure the blood sugar before you intubate. But I would intubate this patient. Yes, I agree. Please call me back afterwards and we'll talk about it. That's how it goes.
It's a little bit like cross-checking.
Exactly.
Right?
Yes, it's very much like cross-checking. Very much like in the cockpit. It's teamwork, but it's remote advice. And the advantage is that one senior experienced person can give advice to hundreds of doctors and paramedics. There is one person on call in Hungary, and every ambulance and every helicopter calls that one person for advice, for intubation. And it works. It's a brilliant system. We learned that in Britain as well, but that's how it is, and it's a great reassurance, and we do make a difference over the phone as well. It's just like in hospital. It's just like a consultation between colleagues.
You've just proved you're a real superstar in case of managing difficult airway. And I'm wondering, are your workshops available somewhere online, or are these informations available for the students to click and have a little bit of homework?
Only in Hungarian. So
Only
if
in
you want-
Hungarian.
yeah,
So
far-
learn Hungarian first, and then.
No, I'm kidding. But I can send these materials electronically to you if you don't have them.
All right. So we'll
That's
exchange.
easy. Yeah, that's easy,
materials.
and you can distribute in English.
Mhm.
It's fine. But let me get something clear. I'm not a superstar in
Mhm.
managing airway or managing difficult airway. My expertise is the emergency level. So you have to know that in the pre-hospital field, that's the maximum you will have. You won't have much more than you and me,
Yes.
because you're there. But in a hospital setting, it's different because you can always ask for more expert help. And more expert help means somebody with a fibroscope.
Yeah, it's not the difficult airway society,
it's-
right? It
no,
is
it's-
for
it's-
the pre-hospital
It's
setting.
advanced airway management,
Yeah.
but it's for your general patient. For your really horrendous, difficult airways, I get into as much trouble as any of us. And in hospital settings, you should ask for help from an anesthetist who is good at fibroscopic intubation and who has the tool, because I don't have the tool and I don't have the expertise. And in the pre-hospital settings, you have to consider to delay the intubation for the hospital phase. And that's the art. Finding the patient who needs intubating by me at that location, at that time. Is this that patient? And many of them are, but you have to consider really carefully.
So, Peter, last question. Would you advise my students to go this path, to follow this path of pre-hospital medicine?
Yes, absolutely.
All right, so you're enthusiast, I'm enthusiast, but if you have your sons or daughters sitting right here in the
Yes.
back of the camera, will you tell them, do that? Do
Yes.
that. It's a good thing. It's not just the first aid, right?
No,
it's
it's
not for just for firefighters or for nurses or for volunteers, as it is in United States. You really can make your dreams come true, your surgical ones, in the pre-hospital setting.
I've done the biggest operations of my life, thoracotomies, I've done in the pre-hospital setting. So you can make your surgical dreams come true if you want to. Yes, first of all, you do make a difference, as I said. And it's adventurous and it's challenging. But secondly, it's not a bad life if you think about it. You've got 12-hour shifts and you go home and you can put down your last patient and you can sort of forget about your last patient. So you're not taking your work life home with you, and it's completely different. Any hospital, even in an emergency department, you will take your patients home with you. Some of your thoughts will be going back, what's happening with Mr. whatever, and I'll see him tomorrow or not. In the pre-hospital field, you hand them over and you're sort of detached. And for your personal life, I think that's really, really beneficial. And you have 12-hour shifts, and you have lots of free time if you want. You can have more free time because a hospital just eats you. And the pre-hospital setting doesn't eat you. It doesn't need to destroy your ordinary everyday life or your family life. So I think it's for everybody.
So, Peter, thank you for your exclusive interview. You're always welcome in Poland, and
Thank you,
I
Lukas.
hope we'll see each other here next time.
Thank you for the opportunity.
So,
See you guys
bye,
next time.
students. Thanks.
Thank you.